Hi, I'm James Brown, a PGY2 with the FSU College of Medicine Internal Medicine Residency Program at TMH, and the title of this clinical vignette is Recurrent Effusion Produces Diagnostic Confusion. My co-authors are Dr. Nikisha Rogers and Dr. Andrea Venturini. Introduction. Gastropleural fistula is a rare communication between the gastric lumen and pleural space. Risk factors include paradiaphragmatic surgery or infection, perforated gastric ulcer, malignancy, tyrosine kinase inhibitors, and radiation therapy. The fistula confers high morbidity and mortality. However, incidence, morbidity, and mortality are unknown due to its rarity. Pertinent history. This 66-year-old male patient was diagnosed with high-grade urothelial carcinoma 6 years prior to presentation. He was treated with transurethral resection and intravesicular chemotherapy. 5 years later, metastasis was identified in his left adrenal gland. Metastatic disease was removed with radical left nephrectomy and adrenalectomy. The procedure was complicated by gastric perforation and left hydrothorax, which required robotic-assisted laparoscopic repair and thoracostomy tube placement. After discharge, he started treatment with radiotherapy, chemotherapy, and then immunotherapy. 1 year later, he had mild COVID-19 infection treated with Paxlovid. He remained on pembrolizumab at the time of presentation. Case. 3 months after his uncomplicated COVID-19 infection, our patient presented to the emergency room for progressive shortness of breath. He was febrile and hypoxic with decreased breath sounds over the left, middle, and lower lung fields. Chest radiograph at that time is shown in image 1, with arrow indicating left lower lobe atelectasis versus pneumonia with moderate left pleural effusion. He started non-invasive positive pressure ventilation and intravenous antibiotics. Left thoracentesis produced 1.2 liters of cloudy fluid and relieved his shortness of breath and hypoxia. Pleural fluid analysis is shown in Table 1 and is notable for LDH of 1536, which is consistent with exudative process by Light's criteria. Neutrophil count was 94, glucose was less than 10, and pH was less than 6.8. Pleural fluid cultures grew Parvomonas micra, and the patient was diagnosed with complicated parapneumonic effusion. He was treated with ceftriaxone, 2 grams IV daily for 4 weeks. The patient returned to the ER after completing ceftriaxone with dyspnea and left shoulder pain radiating to the left upper abdomen. CT abdomen and pelvis with contrast, shown in images 2, 3, and 4, revealed gastropleural fistula, as indicated by the arrow in images 2 and 3. We can see contrast at that level escaping from the gastric lumen and into the pleural space. Image 4 is a more superior axial view in the lung window, showing air fluid level nearly completely displacing the left lung. EGD was performed for confirmation. However, the fistula could not be identified on endoscopy. He was taken to the OR for video-assisted thoracoscopic surgery with pleural fluid drainage. The patient was offered decortication, drainage via chronic gastric tube, and enteric tube for post-pyloric feeds. However, he opted for hospice care instead. Diagnosis. Gastropleural fistula is a rare cause of pleural effusion, and diagnosis is difficult given nonspecific presentation, pleural fluid findings, and imaging. Enteric bacteria on pleural fluid culture or food contents in chest tube output provide clues for diagnosis in some cases. Nephrectomy and adrenalectomy complicated by gastric perforation is the most probable source of this patient's fistula. His urothelial carcinoma and treatment for carcinoma created additional risk factors for fistula. Prompt recognition of these risk factors might have allowed earlier workup and better outcome in this case. When fistula is suspected, providers should obtain imaging with oral contrast to assess for contrast migration across the diaphragm. Options include contrast-enhanced CT, barium swallow, or gastrographin study. There is no general consensus on treatment in current literature. Treatment typically involves gastrostomy tube to divert gastric contents and post-pyloric feeding to prevent reaccumulation of effusion. Fistula may be ablated surgically or endoscopically. Esophageal stent can be effective in certain cases. Even with these interventions, morbidity remains high.